when we take this topic seriously, and I had the pleasure and honor to be a member of this international study group for definition of pancreatic fistula, the problem is that this classification did one thing: it defined one complication so that we were talking worldwide. We were able to talk about one complication worldwide so that nobody could say, I have a fistula rate of 0%, the other clinic 25% or so, when we have this definition. The problem is that this definition does not give us any clue, once a complication arises, how the postoperative course of this patient will be, because it's just a definition retrospectively after we have seen the postoperative course of the patient. So what is the magnitude of the problem? Now, there is a range of incidence of pancreatic fistula when we apply this strict definition of between 2 and 28%. You will see that in my clinic it's 18%. The classification according to the International Study Group of Pancreatic Fistula is only retrospective after completion of clinical course. This is very important in defining classes of patients, how to manage them. Reoperation is required in 2 to 20% of patients with postoperative pancreatic fistula, and obviously the total amylase content in the drain of postoperative day 1 predicts development of postoperative pancreatic fistula, as the group of Claudio Bassi has shown. Now, the incidence of reoperation after pancreatic resection varies a lot. It ranges between 2 and 11%. And when you look at this study, which was done from the group of Bonn, you will see many indications for reoperation: bleeding, pancreatitis, biliodigestive anastomosis insufficiency, gut ischemia, and so on. But obviously, there doesn't seem to be any indication for postoperative pancreatic fistula. Is this true? I do not think so. I think we have a significant amount of patients and a significant percentage of patients who need reoperations. And I will try to address 3 points in my talk. First, who needs the reoperation? This refers to patient selection. The second point, what is the ideal time point when to reoperate? And the third, how to operate. Who needs reoperation? Now, this is a study published in 2009, 35 patients with postoperative pancreatic fistula which were compared regarding reoperation and conservative treatment. As you can see, 20 patients were submitted to conservative treatment, 15 needed a reoperation, and the groups did not differ in any clinical pathological parameter. So this outlines the problem. How are we able to identify patients that will require a reoperation in their postoperative clinical course? And so far, the International Study Group definition has not given us a clue how to manage those patients. So who needs reoperation? In general, conservative treatment, that's at least, let's say, the policy we follow in my institution. In general, the conservative treatment is justified in absence of peritonitis, sepsis, organ failure, or of hemorrhage, a deterioration of the patient's clinical condition, which is very subjective, often directed to reoperation, and there is really no valid predictive score available. Now, we analyzed our patient collective in Hamburg very carefully, and in a time period of 11 years, nearly 11 years, you know that I am there in Hamburg since 18 years, we operated approximately 2,000 patients with major pancreatic resections. The incidence of postoperative pancreatic fistula, and this is an honest number, when we defined when we used the definition which was introduced by the International Study Group, was 18%. So 349 patients had a pancreatic fistula. 6.7% of these nearly 2,000 patients needed a reoperation, and 11.6% were submitted to conservative treatment. And as you can see, the indication for reoperation was manifold. It was postoperative pancreatic fistula in 132 patients, combined with hemorrhage in 63, combined with a sepsis or peritonitis in 13. In 5 cases, there were other reasons which led to this reoperation, 4 in combination with biliary secretion, 4 patients with acute pancreatitis. But this left a considerable amount of patients which did not have any associated conditions, which still needed a reoperation. And when you look at the overall survival for patients with pancreatic cancer and postoperative pancreatic fistula, obviously those patients who were non-surgically treated had a better survival than patients who needed a reoperation. Now, we tried to analyze by a complicated multiple regression analysis model, are there any predictors who might lead us to the judgment whether a patient needs an operation, a reoperation or not? And out of this multiple regression analysis, you could see that bilirubin, serum bilirubin, on the day of onset of postoperative pancreatic fistula, and the serum amylase obviously had the highest prognostic impact on to predict whether this patient will need a reoperation or not. In other words, whether this patient will develop a severe postoperative course. These are very fresh data, and they are being written up now, and they are being submitted to the Annals of Surgery. And I'm very keen on your experience, whether you will see the same results. And as you can see, obviously an elevated serum bilirubin has, maybe this is an epiphenomenon, has an impact, a deleterious impact on overall survival of these patients. And when you look at the multivariate analysis for overall survival, there were just 2 parameters. That's the underlying diagnosis and the serum bilirubin, which was suggestive for overall survival of those patients. And these were the only independent prognostic markers for overall survival in patients with postoperative pancreatic fistula. And in this univariate analysis, 21 parameters, I do not show every parameter here, were analyzed, so these were the only 2 parameters which predicted the outcome. Now, how to reoperate? Now, there was a paper published by my dear friend Markus Bücher, I think it was published in 2000, towards the end of completion pancreatectomy. I think this was a little bit too optimistic. We still have patients who need a salvage pancreatectomy, but it's rarely necessary. In the literature, it's described between 0 and 5%. The question is, do we do a reanastomosis or do we do a temporary takedown and do a secondary pancreatojejunostomy? You see by the Nestor of pancreatic surgery in Germany, Michael Trade, in the remaining 16 patients, the decision to reoperate was often difficult. He was referring to patients with salvage pancreatectomy. And obviously no consensus and no guidelines exist about the operative procedure. So usually the intraoperative picture dictates the individual operative proceeding. Now, as you can see, there were many clinical findings in patients receiving total pancreatectomy in this landmark article published by Trede: tachycardia, peritoneal irritation, fever, gastrointestinal bleeding, abdominal pain, and so on. So these were all predictors of a septic course, but you obviously had back pain, you had dyspnea, and you had a term of changing deep drainage. Now, we had 10 patients with a total pancreatectomy, and as you can see, the majority of patients received delayed operation due to septic or pancreatitis complications. And as you can see, the mortality in those patients was very high. And as you can see, there was a disastrous median overall survival after total pancreatectomy. It's just 1.4 months in those patients who received this total pancreatectomy. The third point, when to reoperate. No consensus exists when to reoperate. It's still an individual decision, very subjective according to the clinical presentation. When I operate a patient and the patient has, let's say, a funny clinical picture, I always take an independent surgeon who examines this patient. This is my rule in my department, the same as I do with another surgeon who has operated on his Whipple. Our linear regression models found very early re-intervention associated with higher mortality, and obviously postoperative pancreatic fistula, as my coworker Emre Yekabash has shown, and hemorrhage required often emergency laparotomy with a very high perioperative mortality. So the time point of reoperation is usually, it's if you have to reoperate the patient early after the diagnosis or the onset of postoperative pancreatic fistula, this is a very dismal sign for the patient. Once it's more than 24 hours after the diagnosis, obviously the course is much more benign. So, unfortunately, the ISGPF classification is retrospective. It has no prognostic answer to the individual course of a patient whatsoever. Up to now, there is no guideline for individual treatment of postoperative pancreatic fistula. And in our patient collective, within 217 type A and B fistulas, 20 patients died due to septic complications, so they had to be reclassified as type C fistulas, but the clinical course of those patients was very benign. They were readmitted and died. So obviously the classification, this classification does not predict severity of the fistula. And in summary, the laboratory data on the day of onset of postoperative pancreatic fistula may predict the further clinical course in terms of amylase and bilirubin. Patients with total pancreatectomy showed a disastrous overall survival. Patients that need early reoperation show a reduced overall survival. And the existing ISGPF classification system is not predictive, though retrospective analysis shows a correlation to survival parameter. Thank you very much for your attention.